Namaste and greetings from the World Health Organization. In this brief presentation, I'm going to give you a global overview of sexually transmitted infections, prevention, and care. This slide contains a definition of the term sexually transmitted infections, or STIs. STIs are infections caused by bacteria, viruses, and parasites transmitted through sexual contact, including vaginal, anal, and oral sex. Some STIs are transmitted through skin-to-skin sexual contact or non-sexual means, for example, from a mother to child during pregnancy and childbirth, or through a blood transfusion. There are a number of STIs that are known. This is one of two slides that provides the rationale for addressing STIs in adolescence. This slide makes 2 points. One is that STIs among adolescents are an important problem. Although data on STIs is patchy, we know from small studies around the world that STI rates in adolescents are high and in some places increasing. The second point is that adolescent girls have a greater biological susceptibility than adult women to some STIs because of the immaturity of their reproductive tract, particularly the cervical mucosa. And this is important. In addition to biological susceptibility, for the reasons explained on this slide, there are a number of social reasons which increase the vulnerability of adolescents to acquiring and then passing on STIs. This is the second of two slides which provide the rationale for addressing STIs in adolescents. Makes 3 points. First is STIs among adolescents, just like in adults, have major health consequences. And they are immediate and long-term consequences within and outside the reproductive tract, the sexual and reproductive organs and tract. The second one is that prevention and management for STIs has been shown to be effective. Several STIs can be cured, others can be managed, viral ones can be managed. The third point is that the design and implementation of prevention strategies and access to good quality services, both for prevention and management of STIs, needs attention. This is an area where attention is required, as we will discuss further. In the previous slides on rationale, we discussed the needs for STI prevention and management services. This slide deals with the human rights rationale. States have an obligation to ensure care and treatment of STIs as part of a package of sexual and reproductive health services. They are obliged to ensure that services are accessible, are free, are confidential, and non-discriminatory. And they are obliged to remove barriers that hinder the ability of adolescents to access these services. In moving forward, we'd like to make 2 points. First is adolescents lack knowledge and understanding about STIs and STI prevention and management services. So they need information and education on both these issues so that they are knowledgeable about STIs and knowledgeable about where they can get help to prevent STIs and to get care if they suspect or have an STI. Secondly, STI prevention and management services often do not reach adolescents, and if they do, they are not responsive to adolescents' needs. This is clearly something that needs to be addressed. In follow-up to the previous slide, this slide deals with comprehensive sexuality education. It contains information about 2 guidance documents on sexuality education produced by WHO and a number of UN partners. One deals with sexuality education in school, and the other deals with it outside the school setting. And in this slide, you see 3 points. Children and adolescents need and have a right to sexuality education. Sexuality education does not harm, it in fact helps. Well-designed and well-delivered sexuality education does good. This slide deals with quality health services. On the slide, you see the title of a WHO document titled Global Standards for Quality Healthcare Services for Adolescents. The attributes of quality are listed on this slide. I won't read them. The principles on which these are based, the quality principles on which these are based, are also shown in the diagram. And so WHO is working with a number of partners to ensure that services are in fact of high quality, both from the perspective of the provider and the perspective of the user. This is the first of 2 slides which contains a list of WHO's guidelines on sexually transmitted infections. This is a long list, and I'll make no attempt to read it out, just to say that all these materials are available on WHO's website, and if you are interested in any particular guideline, you could reach out directly to the Geneva Foundation or to WHO through them. The previous slide listed guidelines on clinical case management. This one lists guidelines on public health policy and strategy development. And here again, what you see is a number of guidelines which are which address both HIV and STI and address different groups. There's again a plethora of guidelines in this area that you could draw from. This slide lists a number of documents that are complementary to WHO's guidelines. A number of these documents have been produced by WHO, but we also have included documents published by other agencies which complement and are consistent with WHO's approach and WHO's normative guidance. In relation to the previous modules, I mentioned to you that WHO worked with UNFPA to publish a technical brief titled Not on Pause, responding to the sexual and reproductive health needs of adolescents in the context of the COVID-19 crisis. STI is one of the health issues addressed, and this is one of 2 slides which lists the specific measures that we recommended. And there are 4 points in this slide. Inform adolescents where and how to access testing and care, where access is possible through mass media and digital media. In health facilities, ensure the availability of diagnostics and medications, and that testing and care are provided discreetly and confidentially. Ensure the availability of condoms and promote their use, and consider waiving any restrictions that exist. This is the second of 2 slides on the same subject. It calls for prioritization of HIV and STI testing for adolescents who are at high risk of infection, as well as those presenting with defined conditions. Encourage adolescents presenting for testing and care to refer their partners. Where possible, provide home-based HIV and STI tests. And finally, use digital platforms and mobile health strategies where and when possible. As in the case of the other health issues, we recommend that as the epidemic comes to a close, or at least into better management, catch-up campaigns are held for testing and perhaps for HPV vaccination, and wherever possible to institutionalize good practices that have been put in place in the context of the pandemic. This slide discusses why STIs are an issue in humanitarian settings. The rationale is presented on this slide, as is the availability of guidance in the minimum initial service package. So please access these materials if you're working or interested in working in the humanitarian settings, STIs need to be an important issue that is addressed within the context of sexual and reproductive health and health in general. This is my last slide in the global segment of this presentation. And what you see here is a huge issue in relation to STIs, stigma and shame, and fears about confidentiality and privacy, as you see in this little exchange. And so this is clearly a hugely important issue for all segments of the population, but especially for adolescents who are beginning their sexual lives. With this, I pass on the baton to my regional colleague who will give you a regional overview of the situation.
Hello and welcome to the regional perspective for STI prevention and care. I'm Dr. V Mugisa. I work with the WHO Regional Office for the Eastern Mediterranean, and I'm based in Cairo, Egypt. On the first slide, we look at the global and regional situation, specifically looking at STI incidence and prevalence estimates. So in terms of the WHO incident case estimates for 4 curable STIs globally and by region, you'll see on this map that for the Eastern Mediterranean region, 34 million new cases are estimated as of the 2016 estimates. You'll also see on this slide the prevalence estimates for the same 4 curable STIs for male and female aged 15 to 49 years within the Eastern Mediterranean region as per the 2016 estimates. In this slide, we look at sexual debut and STIs in the region, and we note a serious dearth of population-based data on issues around sexuality among adolescents. So we have 2 graphs on the slide. The first one looks at a comparison of self-reported prevalence of STIs and STI symptoms versus the annual reporting. And you'll see that for Afghanistan, Egypt, and Pakistan, there is some correlation between the blue, which is the self-reported symptom, versus actual STI diagnosis, compared to the orange, which is the annual report from the country. And you'll note that also in this graph, probably it's only Yemen where there's a big difference between self-reported, which is about 4.9%, compared to the annual report, which is 20% of STI reported. We also looked at the sexual debut before age 15 and age 18, comparing Afghanistan, Egypt, and Pakistan, looking at women aged 15 to 24, the blue, versus 18 to 24, the orange. And you'll see from this graph that sexual debut before age 15 is quite low. It's 10% for Afghanistan, 4% Egypt, 7% for Pakistan, compared to the older age groups 18 to 24 that are shown in the orange on this slide. So this slide goes into the attitudes towards negotiating safer sexual practices among adolescents. Again, we looked at data from the demographic health surveys from Afghanistan, Jordan, Morocco, and Pakistan. The blue represents the ages 15 to 19, and the orange represents 15 to 49 in the first graph. And you see that in terms of women being able to justify refusal of any sexual relations if she knows the husband has sex with other women, those are the proportions noted for each of the countries, with the highest proportions noted in Jordan and the lowest proportions noted in Morocco and Pakistan. On the second graph, again, looking at the attitudes towards condom use if a woman knows her husband has an STI, again looking at the same countries and similar age ranges and age distributions, and we see that for Jordan, a highest proportion of women would say that yes, they are justified to ask for condom use. The lowest proportions, I believe, were reported in the Pakistan cohort during this survey. So we looked at the regional situation, specifically zeroing in on awareness, knowledge, and misconceptions. Different surveys have been done, and we highlight some of the surveys in this slide. A survey among people aged 18 to 25 years in Saudi Arabia in 2018 showed that 56% of women were completely unaware of their sexual health, and only 60% knew that condoms do not provide 100% protection from all STIs. Another study in Iran involving men and women engaged to be married also showed that only 4.5% knew that a person with an STI does not necessarily look ill. 78% were not aware that painful urination could be a sign of an STI, and about half were not aware that presence of sores in the genital area is an STI symptom in both men and women. We also looked at another study in Egypt and the United Arab Emirates involving university and college students, and this showed that only 20% of the participants knew that if one is infected, sexual partners need to be tested and treated, and almost 70% believed that they are more likely to be infected when they are menstruating, sharing toilets, using swimming pools, as well as physical contact, such as handshaking or hugging. Within the region, we've looked at the beliefs and attitudes as well, and we note that there are negative beliefs and attitudes towards people with STIs and about provision of ASRH education and services which are prevalent in the region. We looked at 3 studies in Pakistan, Saudi Arabia, and Iran that are done in different years. In Pakistan, they found that women with STIs tend to be subjected to more blame and judgment compared to men, and this gender-related discrimination was considered normal. And then also more women than men believe that there is no need for sexual education for Muslims, believing that STIs are not an issue among them. The Saudi Arabia study showed that although 90% believed that their partners had a right to know if they had an STI, 55% said that they would ask for a divorce if their partner had an STI. In the Iran study, 62% believe that education about STIs and unwanted pregnancies does not lead to premarital sex, and 62% males and only 27% females believe that young adults should have access to contraceptives before marriage. We reviewed the policy situation for STI prevention and care in the Eastern Mediterranean region. We looked at the Regional Health Policy Survey of 2019, and out of the 16 countries that responded to this survey, we note that 13 of these have a national policy and guideline in place for STI diagnosis, treatment, and counseling. Only 9 countries reported to have a national policy that is well aligned to the Global Health Sector Strategy on STIs as a 2016 to 2021 or the latest WHO guidelines, and 8 countries stated that the policy on STIs requires use of STI surveillance system to monitor the progress on global STI targets. 11 countries have a national policy that aims to reduce gonorrhea incidence. In terms of the regional challenges, we have a number listed on the next 2 slides. One is the slow policy adoption. We note that within the region there is discrepancy between adoption of policy versus implementation, which could be due to various reasons such as lack of resources, the infrastructure, the finances that are in place. There's lack of knowledge. Sexual health is not taught in any formal setting in many countries, leading to very poor knowledge of sexual and reproductive health among adolescents. For example, a study in Saudi Arabia showed that the major sources of information on STIs were internet, books, friends, newspapers, and family. There are also age restrictions, age limitations, placing the conventional and widely acceptable legal age of consent at 18 years, and ambiguous policies preventing access to HIV testing among minors who are sexually active and are at risk of HIV infection. There continue to be misconceptions among both the educated and uneducated populations. For example, a study examining physicians' knowledge in Saudi Arabia reported that almost half of them identified casual kissing as a mode of HIV transmission. On the next slide, we also highlight an additional set of regional challenges, social-cultural factors, their conservative views and social disapproval for sexual health education, which significantly influence the sexual health awareness and safe sexual practices. There's low perceived risk, again due to the social and cultural factors. STIs are not commonly reported in many countries, and this is really mainly attributed to the perception of low risk among Muslim countries, as highlighted in a systematic review looking at attitudes among Muslim women. There's a service provider's attitude, which in most cases is negative and judgmental towards people attending STI services. The cost and infrastructure remain inadequate. A study in MENA documented the reasons for not using condoms included partner's refusal, high prices, low perceived risk of infection. And lastly, weak health information systems with low reporting of STIs that have a bearing on the disease burden. For example, the low reporting of HPV and its relationship with cervical cancer. On this slide, we highlight one of the regional best practice initiatives, and this is MARSA in Lebanon. MARSA is an NGO in Beirut, which was established in 2011 with support from the WHO, Medical and Arabic Foundation for Freedom and Equality, and the National AIDS Program. And the aim of this NGO is really to provide holistic ASRH services to adolescents, adult women, socially and economically vulnerable groups, with a multidisciplinary team in a safe and welcoming environment that is free of judgment and bias. They do have a holistic set of services that are provided, including information and education, voluntary counseling and testing, cervical cancer screening, medical consultation, psychosocial counseling, as well as promotional outreach campaigns. And the key features are: 1, provision of a comprehensive package of services; 2, assurance of a non-judgmental environment with full autonomy and confidentiality for patients; and then lastly, provision of services by trained and friendly professionals. The last slide looks at the regional opportunities, the regional priorities, and these are well aligned to the WHO Global Health Sector Strategy on STIs and the Regional Framework and Action Plan for STI Prevention and Control, which emphasize the need for an integrated approach to STI prevention and control through securing universal access to sexual and reproductive health care services and rights. So in terms of the opportunities, this slide lists 5. 1, there's need to increase access and coverage to testing and treatment of STIs. 2, where feasible, promote integration of STI services into other programs such as HIV and hepatitis. 3, adopt and use new multiplex technologies for diagnosis, such as the dual testing for HIV and syphilis. 4, promote the use of prevention interventions among the high-risk groups. And then lastly, resource mobilization for STI programs. Thank you very much for your attention. We've included a couple of slides with references that you can look into for further information on the STI prevention and care and treatment globally and within the region.